Good morning, everyone. Hope you all are doing well. We are going to get started in just a little bit. However, if you are just joining us, kindly go ahead and open up your chat box. Tell me where you are logging in from. Thank you all so much for showing up early, actually. This is great. I'm really excited to review with you today. Thank you, Tara, Barbara, Mariana, Amber, thank you all for joining. We're going to get started in just a little bit. If you all can hear me and see me, as well as see my slides, go ahead and type in yes into the chat box. Just want to make sure that everybody can hear me, see me okay. All right. Love it. Hope the audio is pretty good. Excellent. We're going to get started in just about a minute or so. If you'd like, and you have a friend studying with you in the library or another classmate, here is the link for the live stream. This live stream will allow others to join in on this event, and I appreciate you sharing this on your social. I really appreciate you all joining me today. We're going to go ahead and get started in just about a minute or so. Make sure you have your beverage of choice. Mine is green tea, because I think I drank a little bit too much coffee today while I was making these slides. So excellent. All right. And if you're just joining us, welcome to the webinar. If you don't mind going ahead and opening up your chat box, saying hello where you are logging in from, that would be absolutely great. Also, on the chat box feature, make sure that you change it to everyone so that we can all engage in the active recall sessions together. Excellent. Tamika from Alabama. Siamrut from right around my backyard. That's amazing. Nice to see you. Thank you for joining. Excellent. Hey, Jacqueline. Nice to see you. Wonderful. Great. Well, it is just about 2 minutes past the hour, and I want to be very respectful of your time today. And so, without any further ado, let's go ahead and get started. A few ground rules. I would like everyone today to just stay very active and engaged as we go through the session. Think of this as doing blocks, which you are doing on a day-to-day basis. It may feel exhausting, especially if you follow this principle. In an age where there are so many dings, pings, and rings, make sure you are doing your part in cutting out distractions. This is going to be essential for you to be successful over the next hour and 15 minutes. My goal is to channel the energy that I have right now to the comfort of your study space. So I hope this brings you a great smile. What we are going to be doing is we are going to be going into block 2 today. And so let me go ahead and change this. If you have not watched block 1 is going to be available on my YouTube channel. Check out the explanations from those set of videos or that video if you have not yet. For many of you, this is your first review with me, and I welcome you very warmly. My name is Rahul. I am a practicing pediatric critical care physician, and I am extremely passionate about medical education, particularly USMLE preparation for both step 1 and step 2. My goal is not only to just prepare you for this exam, but also to make sure you have the foundations to become a kick-ass resident, fellow, and beyond. And so this is my email. I do my best to try to get back to everyone. Sometimes I can be a little bit delayed, especially if I'm working clinically or I'm half asleep on call or something along those lines. But all in all, I am committed to helping students in a very personalized manner. So feel free to reach out. What makes HyGuru very unique is the fact that it is a very strategic active learning approach to Step 2 CK. Many of you know Step 2 CK is a very important exam, especially for residency applications. And so I really want to focus on vignette learning as well as clinical reasoning. As many of you have utilized my Step 1 program, I also in Step 2 have basic science integrations and integrate amongst clerkships, and you'll see that today. I also, with the free 120 review that we're doing, have a very strategic approach to questions. And more than anything, I want to make sure that you have a peak mindset for peak performance. Whenever I work with students one-on-one, I have this triad: content integration and clinical reasoning, test-taking psychology, and I utilize Notion, which is a really nice platform so that students can, number one, schedule their progress and schedule out a plan, but also make sure that they are going to be taking UWorld notes in a very systematic manner. Most importantly, and we have a small but mighty crew today, 70 students. That's great. I love it. HyGuru is a true lifelong community of learners, and I am very excited to not only announce that Block 1 has been posted on my YouTube channel, but I have continued to update my Step 2 course. I just recently added a whole section on risk factors, very high yield. We're going to be covering a few risk factors today, but I would highly encourage you to join that review session and my rapid review Step 2 CK course. It is on my website, hyguru.com. Feel free to let me know if I can go in and or go and answer any questions that you may have. And many people are saying that they are seeing the Block 1 on YouTube as well, which is excellent. Here are some success stories from the very near future. And this one was great in the sense that the course has helped a student who recently took it jump about 40 points. And so I don't think it's just the contents in the course, but I think it is the delivery and also the fact that the course allows for you to stay structured and with a good mindset so that when you're doing NBMEs, CMS forms, or even UWorld blocks, you can be optimized and engaged. So without any further ado, that is the introduction. I'm going to go ahead and get started. Today, we are going to be going through the new Free 120, which was released circa 2020, 2021. As I mentioned, we've done Block 1 already. This is going to be Block 2. And if you have not checked out for the very new Free 120 released in 2023, if you have not checked out my website under resources, I have a section where I detail all the explanations from there. So I hope that this review, as well as the explanations, will help you effectively cover the concepts from the Free 120. How we will be going through this webinar today is I'm not going to just keep reading these long ass vignettes. What I have done is I have gone through every single vignette and I have truncated it into an illness script. Many of you who have worked with me who are in the course know what I mean when I say an illness script. And so I have made shortened vignettes that give you the essential pertinent positives and relevant pertinent negatives so that then we can go through each of these questions step by step. And I will be also going through a brief explanation of the incorrect answer choices as well. What I want to really emphasize is that all USMLE questions, including these chart-based questions, have this general flow pattern: the chief complaint, the HPI, the patient's past medical history, medications, social history, family history, And then suddenly you stop and you switch into a more objective perspective. And that objective perspective comes with the vital signs, physical exam, labs, imaging, and then they ask you a specific question after you recognize the diagnosis right here. All right. Well, we're going to get into question 1 of 40. Are you all ready to join me? Yes, no, maybe so. Go ahead and type it into the chat box. Now, just to set the expectation, some of these questions, I'm going to invite you all to read through and go through the answer and put it in the chat box. Others, I will go through so you can see how I can break down the reasoning pattern. But please, I highly encourage you all to stay active and engaged through this whole block of questions. Just think, if you do these questions with me, you also get a review, and all of this is going to be in a nice hour and 15 minute, maybe hour and a half tops review. All right, let's go ahead and get started with our first question. We have acute severe abdominal pain, bilateral lower extremity pain in a middle-aged male with a recent myocardial infarction 5 days ago, complicated by extensive anterolateral akinesis of the left ventricle on recent echo. He now presents with tachycardia, tachypnea, hypotension, absent lower extremity pulses, decreased strength, decreased sensation in the lower extremity with differential cyanosis. Which of the following is the most appropriate explanation for this patient's clinical findings? Is it A, aortic dissection, B, aortic embolism, C, pericardial tamponade, D, right ventricular failure, or E, ventricular rupture? What do you think is the best answer here? Excellent. So the key to this question is recognizing that the patient had an akinesis of the heart muscle after a myocardial infarction. This akinesis, the USMLE wants you to know, relates to stasis from Virchow's triad. That stasis then can lead you to have a mural thrombi. And if you have a mural thrombi, then what ends up happening is that you are then going to have the risk for embolization. And that embolization now is going to be in major abdominal aortic vessels as well as lower extremity vessels. And thus, as a result, you have signs of end organ damage. So the best answer here is going to be aortic embolism. Remember, acute aortic dissection typically is going to present with hemorrhagic shock. You won't necessarily get differential cyanosis, i.e., it will be a global hypotension everywhere, not just the lower extremities. And remember, the aortic dissection, typically you're going to be thinking of some sort of aortic disease or hypertension / atherosclerotic, whereas this patient had the disease more so in the left ventricle. All right, let's move on to our next question. We have chronic progressive shortness of breath in an elderly male smoker who now presents with hypoxemia, dyspnea, fine crackles, digital clubbing, no JVD, and chest x-ray significant for scattered reticular opacities bilaterally. Which of the following is the most appropriate next step in management? Would you get an echo, high-resolution CT scan of the chest, lung biopsy, serum anti-glomerular basement membrane antibody assay, or get a thoracic PET scan? What do you all think is the best answer here? And if you want to push yourself, you can even put in what you think the diagnosis is as well, so that then you can activate the illness scripts as I read. So in this patient who has somewhat, signs that he has lung disease, the crackles now are going to represent either fluid or fibrosis. Now, one thing that is important is that fluid can be transudative and exudative, but let's talk a little bit about transudative fluid collections that can then give you crackles. This is typically going to be seen in congestive heart failure. And in congestive heart failure, particularly left-sided systolic dysfunction, you can get JVD because of the backup. This patient, however, is going to have digital clubbing, which is a sign of chronic hypoxemia. That, coupled with the fact that there are reticular opacities bilaterally, indicating that there is interstitial lung disease, both of these, along with the fact that there is no JVD, rules out heart failure. And as a result, you want to look at the lung parenchyma, and that is going to be B, high-resolution CT scan of the chest. Now, remember, there are screening guidelines as well for male smokers, and this integrates family medicine. Remember that the screening guidelines suggest for screening low-dose chest CT scan in patients who are 50 to 80 years old with around greater than 20 pack year history or who have quit in the last 15 years. That is a one-time low-dose chest CT scan. Remember that high-resolution CT is going to be primarily for diagnostic. The low-dose CT is going to be for screening. And recognize that the better answer here is going to be most appropriate next step in evaluation, which then tells us that we do not necessarily go with the scalpel to the lung before we get some sort of scan. And that is a very fundamental principle for surgery questions. You usually get imaging before you are going to go for surgery. That's how surgeons think. Also recognize that imaging would not be indicated if the patient is going to be hemodynamically unstable. So in the vignette, you have to look for the vital signs. And if the vital signs show hemodynamic instability, well, then you're probably going to go for XLAP, depending on the context. All right. Our beloved arrow questions. Let's go ahead and go through this question. Acute weakness and hematemesis in a young female athlete who has chronic vomiting secondary to purging behavior, who now presents with tachycardia, tender parotid glands, and poor dentition. Results of laboratory studies are going to show which of the following in the blood. We have potassium, chloride, and bicarb. So as I was reading this, you probably were thinking that the patient has some sort of eating disorder. Remember, patients with anorexia can also have these purging behaviors. However, the key to differentiate bulimia versus anorexia nervosa is that anorexia nervosa has a significantly low BMI, like it'll be 18 or less, whereas bulimia has sometimes a normal to slightly elevated BMI. Now, whenever you're thinking of chronic hematemesis, you may want to think of, especially with subacute hematemesis, Mallory-Weiss tears. And remember, Mallory-Weiss tears are going to be tears at the GE junction. The other thing you think about with subacute hematemesis is varices, but in this case, the patient does not have any history of alcoholism or any sort of signs of portal hypertension. What we notice is we have the classic findings for a patient who has purging behaviors. The tender parotid glands, because of the fact that you can get some parotitis as the acid just keeps coming out from the gut out of the mouth. Poor dentition, because the acid erodes the teeth. And so as you are going to vomit, you are losing a lot of hydrochloric acid. The other thing is that you are going to activate RAS. And if you activate RAS, you are going to pee out more potassium and you're going to pee out more H+. So the bicarb being increased, the metabolic alkalosis that you get is going to be twofold. Number one, loss of hydrochloric acid. And number two, activation of RAS and the contraction alkalosis that you can get. Remember that the chloride is going to be low because of the fact that you are going to lose hydrochloric acid from the gut secretion. Now, One of the things that I also want to integrate here is for your pediatric shelf, a patient who is going to present with hypokalemic, hypochloremic, metabolic alkalosis is going to also be pyloric stenosis. Now, pyloric stenosis, remember, is it going to be bilious or non-bilious emesis? Go ahead and type that into the chat. Is it going to be bilious or non-bilious? Excellent. And again, I'm going to give you some active recall questions, so please stay on the edge of your seat. And the answer is absolutely, it is going to be non-bilious. Contrast that from duodenal atresia, which is going to be bilious. Remember that the first step in management for both of these patients is going to be rehydration. And for this patient, if they had anorexia nervosa, one of the key vignettes they can ask you is, I initiated feeds. What are you worried about? Refeeding syndrome. And in refeeding syndrome, the USMLE loves for you to know that you get hypophosphatemia and a propensity for arrhythmias. And the hypophosphatemia has a beautiful basic science mechanism, and that is that I am going to now take food. That food is then going to get absorbed by my body. And as I get that food, I have been chronically malnourished. So the insulin is going to release, bring that food into the tissues. The tissues are going to start trying to make ATP. And as they're trying to make ATP, they're going to take the phos from the intravascular space into the intracellular or tissue space. And subsequently, you're going to have hypophosphatemia. Next question. Here we go. Chronic painless hematuria in a middle-aged smoker with history of deep vein thrombosis on warfarin therapy, hypertension, and benign prostatic hyperplasia, who now presents with hypertension, prostatic enlargement, normal PSA, normal creatinine, and UA significant for hematuria. In addition to a CT scan of the abdomen, what would be the next step in management? A, adjusting the warfarin dosage. B, ciprofloxacin therapy. C, cystoscopy. D, discontinuation of hydrochlorothiazide therapy. Or E, finasteride therapy. Go ahead and please participate. If I have not heard from you, kindly open up your chat box. So this patient is going to have painless hematuria and is a smoker. I'm going to give you a little bit of a riddle. Painless hematuria, think about bladder cancer. Painless jaundice, think about what condition? Go ahead and type that into the chat. Ah, yes, pancreatic cancer, particularly pancreatic cancer of the head of the pancreas. You got it. Very good. So in this case, the patient has 3 past medical histories. And whenever you think about 3 past medical histories, my test taking strategy is that the USMLE, it may be testing a very important complication of one of those past medical histories. For example, you can get bleeding when you have a supratherapeutic INR. But in this case, the patient in the original vignette had a normal INR. And so we should not consider that as part of the cause of the bleeding. They had an INR that was around therapeutic, which was 2.5, not supratherapeutic. The other thing to note is that this patient does not have a UTI. There's no leukocyte esterase, no nitrites in the original vignette. And recognize that his PSA is normal, and we don't necessarily have any signs of prostatic cancer. So finasteride and going down that route is not necessarily going to be indicated. And so when you see smoking and painless hematuria, you're going to be thinking of doing cystoscopy because you're worried about bladder cancer. Now, remember that this is primarily going to be a bladder cancer that is going to be transitional tissue, which is going to be the bladder tissue. You can also get squamous cell carcinoma of the bladder, And that is primarily going to be associated with schistosoma hematabium. So in the vignette, in the social history, they may even say that the patient is from a Middle Eastern country. The other thing that I want you to note here is the fact that when you are going to have BPH, BPH can cause you to have post-renal injury. So severe BPH can cause such a bad outlet obstruction that your kidney ultrasound can show bilateral hydronephrosis. What PEDS vignette has bilateral hydronephrosis associated with it? That is going to be posterior urethral valve. And remember that posterior urethral valve can also, in utero, give you oligohydramnios. There's your OB, Cayenne. Welcome to this journey. It's super fun. Let's go ahead and go into this next question. But before I go any further, are you all enjoying this review so far? Everybody doing okay? Excellent. Just trying to incorporate questions step by step. And I thank you all for your participation. So many familiar faces. This is awesome. All right, let's go ahead and go through this question. We have acute unilateral severe groin pain in a young female who recently suffered a motor vehicle collision. She now presents with severe pain at the right hip and X-ray showing completely displaced fracture of the femoral neck. In addition to IV morphine, what would you do as the next appropriate step in management? A, bed rest. B, closed reduction followed by traction. C, hip spica hinge brace. D, limited weight bearing with the use of crutches. And E, operative reduction and internal fixation. What would you do here, everyone? Excellent. Remember that if you have a displaced fracture, that is sometimes very hard to reduce just at the bedside, a closed reduction. So that's why you may have to go open in the operating room. But at the level of the hip, this is very important. You run the risk of avascular necrosis. And that is because the circumflex vessels at the level of the hip are going to be very flimsy. And so avascular necrosis in your PED shelf, if it is going to be idiopathic, let's say that you have a child who is about 7 years old that is going to have this gnawing groin pain and a limp, you want to be thinking about leg calf Perthes syndrome. Avascular necrosis on your PED shelf also could be related to sickle cell. And you want to relate avascular necrosis to steroid use as well. Now, another important area that can undergo avascular necrosis for MSK is going to be where you have a fall on the outstretched hand and then pain in the anatomic snuff box. And this is where you're going to be thinking of a scaphoid fracture. And remember, a scaphoid fracture is going to have this pain, and they'll say it in a way that there's pain at the near the tendon of the extensor pollicis longus and brevis and all of that, but just it's the anatomic snuff box. And so what you want to note here is the fact that avascular necrosis can lead to chronic bone ischemia and joint arthropathy. And that's why you want to really make sure that you operate on this quickly. Hip spica cast, this is going to be a good answer choice if you're worried about congenital developmental dysplasia of the hip. So congenital developmental dysplasia of the hip, typically they will say that the baby has unequal gluteal folds. They also will say that the baby is going to have a hip clunk and breech delivery can also be associated, or breech positioning can also be associated with congenital hip dysplasia. And so we do screening at around 2 to 4 months with a hip ultrasound just to make sure. All right, very good. Let's go ahead and go through this question. We have acute self-resolved slurred speech and unilateral hand clumsiness in a middle-aged overweight male with a history of uncontrolled hypertension, hypercholesterolemia, and history of transient focal neurological deficits, who now presents with moderate hypertension, normal neurological exam, and a fully oriented state. Which of the following is the most appropriate next step to decrease this patient's risk for subsequent cerebral infarction? Here's your risk factor question. Go ahead and put in, as you're going through this, what would be the diagnosis? Go ahead and type that into the chat. What would be your diagnosis you would consider here? Excellent. Yeah. Especially because if it was self-resolved, you would worry about a TIA. And so one of the things that you want to note here, and that's why the risk factor section in my course is so powerful, is that the USMLE will give you kind of all things that are bad. They'll say, oh gosh, he's a smoker, he's overweight, he has hypertension, he has hypercholesterolemia. And what they're going to ask you is which one is the most associated with a certain condition. So in the setting of strokes and TIA, remember that hypertension is going to be the most modifiable risk factor. Strokes associated with hypertension, exceedingly high yield. If they gave you, for example, I have a patient with new hypertension, then losing weight is going to be the best thing you can do for that hypertension, along with smoking cessation, but particularly weight reduction. So the point here is to recognize that antihypertensive therapy is going to be something that we can modify as we have this patient who presents with cerebrovascular disease. All right, next question. Which of the following is the most likely infectious etiology? We have a patient with acute, moderate headache, dyspnea, malaise, and myalgias in a young, preemie-gravid, second trimester female who recently immigrated from India 6 months ago, who now presents with fever, tachycardia, decreased breath sounds on the right lung base, and very characteristically, right-sided interstitial infiltrate. Which of the following is the most likely etiology here? A, Haemophilus influenza, B, influenza A, C, Legionella, D, tuberculosis, E, Pseudomonas, or F, Streptococcus. Lot of varying etiologies here. And I love how people are saying that, okay, it could be tuberculosis. However, recognize that this is going to be a right-sided interstitial infiltrate, not an apical infiltrate. And so the best answer, especially with myalgias and the interstitial infiltrate, most likely this is going to be a viral pneumonia. So the answer is going to be B, influenza A virus. Now, many people are going to, and even other tutors, and that I know kind of hate on that, but other tutors may say, hey, you know what? That's a trick. They're trying to trick you. And what I will try to tell you is that they are trying to assess you. They're trying to assess whether or not you can see a patient's risk factor and then stratify whether that risk factor is correlated to the disease or not. These flu-like symptoms, one of the things that is classic in flu is myalgia. So anytime you have muscle pains, think about flu. What we have to note is that if I change this question and I said that I have bilateral interstitial infiltrates with the same type of symptomatology, but it was bilateral, you may be worried about mycoplasma pneumonia. And that's called that walking pneumonia. Now, mycoplasma pneumonia, what is the antibiotic of choice? Go ahead and type that into the chat. Antibiotic of choice of mycoplasma pneumonia or walking pneumonia. Excellent. It's going to be azithromycin, which is going to be a macrolide. Very good. You cannot use penicillins because of the sterol wall made up of cholesterol. Now, another thing for us to note is that viral pneumonias are going to have an interstitial pattern. So interstitial relate to a viral pneumonia. However, if I change this vignette and I said that the patient has positive influenza and now multifocal lobar infiltrates, what would be the likely organism? And that would be Staph aureus. Remember that Staph is going to be the most common cause of pneumonia, status post a flu-like illness. Very high yield. I hope you understood some of the key integrations here. Let's go ahead and go through this question. Chronic decline in school performance, frustration with inability to meet expectations in a school-age developmentally appropriate boy who now presents with, look at these pertinent negatives coming at you, normal audiometry, normal visual acuity, and having significant difficulty sounding out unfamiliar words. So he has this frustration, developmentally normal, a lot of pertinent negatives, and that is going to be leaning into a learning disorder. You're absolutely correct. Now, what is high yield for us to note here is that if they gave you a patient with just learning difficulties or even ADHD type of symptoms just in the classroom, the first couple steps in management, and they won't test all of them at the same time, is get vision, get hearing, and get a sleep study. Woo! These are going to be key organic etiologies that we must rule out before we just go down the route of diagnosing a learning disorder. Let's go through this question. Subacute unilateral pruritus of the ear in a young female in the Air Force who now presents with pain, with pulling of the pinna, an erythematous and edematous ear canal, tympanic membrane not fully visualized due to cerumen. I'm going to pause and I'm going to ask you, type in the most likely treatment you would give this patient. What is the most likely management that you would do for this patient? Go ahead and type that into the chat. I don't want the right answer. I want what you would give. Very good. Very good. Excellent. Remember that this Air Force pilot might be wearing earmuffs and stuff like that. That is a wet, arid climate. Relate this to Pseudomonas. Another thing for us to note is that when you have pain on manipulation of the tragus, that pain on the manipulation of the tragus is very characteristic of the illness script of otitis externa. And because you want to cover Pseudomonas, the best answer is going to be otic ciprofloxacin. Sometimes we even put a wick in there as well. The edema of the ear canal, that again is going to be the inflammation of the outside of the ear. Remember that if the tympanic membrane was bulging, erythematous, with a decreased light reflex, then you may go down the route of otitis media. But that typically is going to be a diagnosis that you would see in a pediatric patient. So best answer here is going to be otitis externa. The other demographic besides somebody with wet earmuffs is going to be a swimmer. All right, we are just about halfway. Let's go ahead and go through this question. Acute headache, purulent nasal discharge, and unilateral facial pain in a young U.S. Army female with history of chronic bilateral knee pain who is now afebrile and presents with unilateral maxillary tenderness, inflamed nasal turbinates, and scant purulent discharge in the oropharynx. Which of the following is the most appropriate next step in management of this patient? Would you do a CT scan? Would you do gram stain and culture of nasal discharge? Ibuprofen and decongestant therapy? Trimethoprim sulfamethoxazole therapy? Or x-ray of the sinuses? What would be your next best step in management? So one of the key components that I will turn your attention to is that, yes, you are probably activating the illness script of sinusitis. And so anytime you are going to call out an infection or activate that, hey, this is going to be an infection, what I would do is I would try to stratify that is, do we have bacterial, viral, or fungal? Let's get this one out of the way. Fungal, sinusitis. You get black eschar, fungal, sinusitis, mucor, rhizopus. Hello. What would be in the past medical history for that patient? Go ahead and type that into the chat. What would be in the past medical history in the vignette for that patient? Ah, very good. Uncontrolled diabetes. Love that. Other things that you could be thinking of are immunocompromised patients that can have fungal sinusitis. Now, between bacterial and viral, these patients are much more toxic. They have fever. They are going to have this green discharge. And they had a prodrome of a URI that lasted about 10 days, and then it got worse. These are all going to be signs and symptoms of bacterial sinusitis. But this patient is going to have some level of rhinitis, has purulent nasal discharge. Don't go by the color. It's just purulent nasal discharge and a little bit of postnasal drip. And so, yes, could there be a lot of sinus congestion here? The answer is absolutely. But more so, this is going to be a viral sinusitis, and you're going to employ first decongestant therapy. Now, remember, decongestant therapy, you could use phenylephrine as one of the decongestants. Pseudoephedrine is another one. But remember that phenylephrine, pseudoephedrine, both of those are going to cause you to have alpha-1 vasoconstriction. And these are going to be one of those medications that you want to use only for a short amount of time. Because when you use phenylephrine and pseudoephedrine for a long period of time, you can get something known as tachyphylaxis. Now, tachyphylaxis is this concept where you are going to keep giving the med, but after a while, it paradoxically does the exact opposite, or you need higher and higher doses of it. And so that's where you kind of limit the trial of those decongestants. So best answer here is going to be a sinusitis, utilize ibuprofen and decongestant therapy. Typically for bacterial sinusitis, again, it's more so of a clinical diagnosis. And thus, we would not employ Bactrim therapy. Typically, we would do amoxicillin or Augmentin, which is going to be amoxiclav, as your likely treatment options. All right. Let's go ahead and go through this question. We have subacute, harsh cough in a teenager with Vater syndrome. Vater stands for vertebral abnormalities, anal atresia, tracheoesophageal fistula, and renal anomalies, who now presents with mild tachypnea and a harsh vibratory sound in the mid-anterior chest with forced expiration, a low forced vital capacity, and a slow vital capacity greater than the forced vital capacity. There's scooping on the expiratory limb. Which of the following is the most likely etiology? And what is the most likely cause of the discrepancy between the patient's forced and slow vital capacity measurements? A, is it bronchospasm? B, is it laryngeal breaking? C, a subglottic mass? D, tracheal collapse? Or E, upper airway compression? Beautiful question here. Beautiful question. Go ahead and think about this one. Type in the answer into the chat box. I want to congratulate each and every one of you. You all are crushing it. We have about 20 more questions, and then we are out of here. You got this. All right. So one of the things that I am very astute about when I'm taking questions is if they have a past medical history of some issue, in this case, tracheoesophageal fistula, they could be predisposed to a complication of that past medical history. Now, what we notice here is that there is some obstructive lung disease in the sense that we have the vital capacity that is going to be greater when the patient is going to exhale very slowly. As they exhale very slowly, they are going to get more air out. Now, what is high yield for us to know is that patients who are going to have tracheomalacia, if you just do a regular breath, there are shearing forces on the wall that then just collapses the trachea. However, in green, if you are going to do a slow breath, you can get a little bit more air out. And that's why a slow vital capacity that is greater than a forced vital capacity is going to be indicative of tracheomalacia. Also, the fact that he had tracheoesophageal fistula, potentially given his past medical history. So tracheomalacia is going to be here. Laryngomalacia is going to be more so upper airway. Now, laryngomalacia, a few things that you want to be thinking of with laryngomalacia, it is positional squeakiness in an infant. So what they'll say in the vignette is when you place the patient supine, they get louder and louder. They're noisy breathing. When you're thinking about upper airway obstruction, that is going to be for subglottic mass. Remember that gives you a fixed flow volume loop. Upper airway compression, this is very characteristic of a aortic ring. And this, again, gives you stridor. However, this stridor is going to improve when you extend the neck because you then open up the airway and the esophagus area a little bit more. So best answer here is going to be tracheomalacia. Remember that we talked about laryngomalacia, and then we talked about a aortic ring, and that is going to be an aortic arch abnormality that can give you positional stridor. Before we move on, I just want to check in with you all. Everybody doing okay? Understanding some of these integrations here? I want to go at a moderate pace here. This is a push pace. This isn't just a fly through it just to get it done with, but I also don't want to have a long lecture on each of these as well. All right, thank you. Acute progressive positional severe substernal chest pain in a middle-aged male with history of hypertension, GERD, and recent URI, who now presents with fever, friction rub, mild elevation in ESR, normal serum troponin, and diffuse ST segment elevation. So you have a URI, and then you have friction rub and diffuse ST segment elevation. what would you do next as the next best step in management? Excellent. You want to visualize the pericarditis, and most importantly, you want to worry about any complication. So here you have inflamed pericardium. That inflamed pericardium can then get you some fluid here. And if you get too much fluid, your diffuse ST segment elevations can turn into electrical alternans. Electrical alternans. And that is going to be associated with cardiac tamponade. Very good. One of the key things that I want you to recognize is that after a URI, you could get pericarditis, myocarditis. Myocarditis typically presents with congestive heart failure-like symptoms plus fever. They are also going to present myocarditis with isolated sinus tach, or maybe even a ventricular arrhythmia, wide complex arrhythmia. But then finally, what's high yield for us to know is that because it's myo, the muscle is going to be damaged, your serum troponin could be elevated. All right, this is the same patient. Echocardiography shows a small pericardial effusion, no tamponade. On exam, an hour later, the patient's symptoms and examination are unchanged. Vitals are within normal limits. Which of the following is the most appropriate next step in management? Clopidogrel or aspirin, ibuprofen and colchicine, oseltamivir and acetaminophen, pericardiocentesis, prednisone and tramadol. What would you think is the best answer here? Excellent. This would be the answer if you were worried about acute coronary syndrome. However, pericarditis, one of the things that I like to do is if I recognize the diagnosis, as soon as I read the question and say, oh, this is the diagnosis, I do a 1-second pause and chant out a sentence that represents the pathophysiology of disease. So I say pericarditis, a viral URI, just triggers a lot of inflammation between the visceral and parietal pericardium. Now, how do I reverse inflammation? Well, give NSAIDs and tell neutrophils with this microtubule inhibitor, say, neutrophils, you're not allowed to come to this region, i.e., colchicine is a microtubule inhibitor that reduces the neutrophils getting to the site of inflammation. We use colchicine also in gout therapy as well. Remember, colchicine is going to be renally metabolized, so watch for your creatinine. And so if the patient can't get ibuprofen, can't get colchicine in the setting of gout, then you may need to do intra-articular steroid injection. Let's go ahead and keep going with our review. Acute eye pain and visual field loss in a young woman with recent history of subacute leg weakness and hiking expedition in Northeast USA. She now presents with hyperreflexia of the lower extremities, ankle clonus bilaterally, and absent pinprick throughout the lower extremity, with an ophthalmology exam confirming the visual field loss. Which of the following is most likely to confirm the diagnosis? A, CT of the spine, B, an EMG, C, an LP, D, Lyme concentration, or E, MRI of the brain. And so again, you all are doing wonderful with activating illness scripts based on demographic. It's like, oh yeah, travel, yeah, all travel people, Lyme. Remember, illness script differentiation. Lyme disease does not cause you to lose your vision acutely, i.e., optic neuritis. Ankle clonus, hyperreflexia. These are upper motor neuron signs. And so the best answer here is multiple sclerosis. And so you need an MRI of the brain, and the MRI of the brain may confirm periventricular plaques. Now, that confirms the diagnosis. Another thing that you could do is you could see oligoclonal banding on LP. But most likely, the patient in this setting needs MRI of the brain. Remember that periventricular plaques represent the oligodendrocytes that are going to be attacked by the T helper cells. So please note, everyone, that the goal is not to have recognition as a surrogate for mastery. It is illness script differentiation. And that is why when you get questions wrong in UWorld or NBMEs, don't just keep doing D is wrong because, and then just like write that down in an Anki card or something like that. What you should be doing is you should be going back into the vignette and say, oh my gosh, okay, I got Lyme because of the Southeast Ohio or the Northeast USA. But now these are the things, hyperreflexia, optic neuritis, that should have told me this is more upper motor neuron disease rather than a tick-borne disease. And so that is where I went wrong. And so it's kind of like a car that detours. That's what you want to do with your thought process and the neurons as you learn. Next question. Chronic difficulty recalling names of people and objects in an elderly female teacher who now presents with no difficulty with activities of daily living, finances, or shopping, who now presents with delayed recall of 5 words, however, intact serial 7s, intact attention, physical exam, showing no abnormalities. Which of the following is the most appropriate next step in management? Amyloid plaque imaging, determination of ApoE allele status, beta amyloid in the CSF, MRI of the brain, or no additional testing? What do you think is the best answer? Serial 7s is when you are counting up by 7, and that is a marker of cognitive executive function. And so one of the key things for us to know, whenever you see that this is normal aging or this is normal behavior, you want to always pay attention in vignettes. Are they able to still maintain their ADLs? If the answer is yes, then most likely this is just going to be normal aging and no additional diagnostic testing is needed. I never really like to teach to the answer choices, but this question was a good reminder that all of these are Alzheimer's and this one sticks out like a sore thumb. What I focus on is not necessarily teaching to the answer choices, but primarily having a student recognize the fact that she is an elderly female teacher, the fact that she has intact ADLs, majority of her cognitive assessment is normal. And so a lot of this is going to be normal aging. I want you to essentially recognize the illness script more than anything. Now, another very important delineation or thing that you want to keep in mind here is the fact that patients who are going to have a decline in ADLs or finances or shopping, that would be very indicative of Alzheimer's. And in Alzheimer's disease, typically what they say is they say that the patient is brought by the husband or the child, because patients with Alzheimer's disease sometimes don't know that they are forgetting things. They don't think it's a problem because it's a neurodegenerative condition. However, normal aging patients typically have that insight that, man, my memory was just not as good as before, and they come in with that chief complaint. Acute behavior changes in a middle-aged male with history of depression controlled on paroxetine and duloxetine, who now presents with an empty pill bottle, fever, tachycardia, hypertension, diaphoresis, bilateral mydriasis, spontaneous myoclonus in the upper extremities. After admitting the patient for observation and supportive care, what would be the next best step in pharmacotherapy? Add carbamazepine, add dantrolene, add haloperidol, discontinue paroxetine and duloxetine, or switch from duloxetine to olanzapine? What would be the best answer here? So one of the things that the USMLE just wants you to note as you become a resident or as you practice independently is you always want to look at acute chief complaints, especially within the hospital, etc., as a what was the underlying trigger and can I just reverse the underlying cause? For example, what if I gave you a blood transfusion hemolytic reaction? Well, yeah, the USMLE is going to say, stop the blood. Because sometimes in the heat of the moment, it's really hard for someone to conceptualize that. And so the point here is that this is serotonin syndrome. It was an acute ingestion. So you just want to make sure that you don't give them too much serotonin, SRI, and SNRI, which is duloxetine. Please note that a high amount of serotonin is going to be seen in serotonin syndrome and is also going to be seen in carcinoid disease or syndrome. And both of them have myoclonus, GI cramping. And as you can see, the mydriasis, the fever, tachycardia, hypertension, these are all signs of a pro-serotonergic or even sympathetic state. But as we note here, the patient had empty pill bottles of the SSRI, SNRI. So rather than a random FIO, especially with the myoclonus, you want to think about serotonin syndrome. Treatment at times can be with cyproheptadine, a serotonergic antagonist. All right, we are rounding out this webinar. Is everybody doing okay? Hanging in there? All right, I'm going to pose a quick little break question here. Coffee or tea? Who's a coffee versus tea? What do you think? Favorite study beverage? Okay, nice. A lot more coffees. I'm a coffee as well. And I probably had a whole pot of coffee this morning. So I'm like, so that's why I did a little bit of tea. I like that. All right, very good. Thank you, guys. Chronic paranoia and mistrust in a young male who now presents with mistrust of doctors, feeling like an external environment is conspiring against him. Normal physical exam, normal labs. Which of the following is the most appropriate step? Begin clonazepam, begin risperidone, begin sertraline, determine his support system, determine whether he has thoughts of harming himself or others, or determine the patient's adherence to medications. What do you think is the best answer here? Excellent. So this patient has this paranoia, signs of psychosis. I don't have a timeline, so I just say signs of psychosis. And so you want to make sure that he's not acutely suicidal or homicidal. Another very important thing for us to know is that if the patient has these kind of symptoms acutely, the next best step in management is a tox screen. And that tox screen can give us some insights. So any sort of acute altered mental status, you want to be thinking of toxins and metabolic. That's very high yield. Acute right upper abdominal pain, pruritic rash in a young woman with a renal transplant 2 years ago on immunosuppressant agents. She now has fever and a physical exam consistent with the pruritic vesicular rash with clear yellow fluid on face, scalp, chest, and back. Which of the following is the most appropriate pharmacotherapy? So please note, when you see transplant patients, you should say immunocompromised. And that should make you think of two things. Number one, it could be thinking of rejection, especially if they have a solid organ transplant. And number two, it may be related to the fact that this patient may have an opportunistic infection. Now, what opportunistic infection could lay latent in the dorsal ganglia? Varicella, herpes. And so best answer here is going to be A, acyclovir. Remember that pruritic and vesicular, that should make you think of herpes. If you went down a GI route, you want to be worried about dermatitis or pediformis, or herpes could be VZV, HSV. And remember, VZV, shingles, is going to be in a dermatomal distribution, and that's high yield for us to know. Acute profuse vaginal bleeding in an elderly female with history of cervical dysplasia treated with cold knife cone biopsy or cold knife cone biopsy of the cervix, who now presents with tachypnea and large verrucous lesion on the perineum, partially covering anal verge, and atrophic changes because she's elderly and may not have the estrogen. Which of the following is the most likely explanation for these findings? All right, so I get a chat that it sounds like cancer. You're absolutely correct. Verrucous lesion. And so what we want to note here is that, remember, this is on the outside. This is on the perineum. And the outside is known as the vulva. And so vulvar carcinoma is key. Remember that if these are the legs, and this is going to be the clitoris, and this is going to be the labia majora, the lesions are going to be here. And it is going to be covering the anal canal. And so this is vulvar carcinoma, most likely HPV 16 and 18. The goal here, because I know many of you put cervical carcinoma initially, is you want to not reflexively answer questions. Imagine the patient in front of you. If you can imagine the patient in front of you, that's why when I text my students, good luck, I say, this day at Prometric, you are here to see whatever, 280 patients. Each patient, each question, you want to think systematically and organized. Best answer, vulvar carcinoma. We have chronic, soft, non-tender nodule in the unilateral thyroid gland in a middle-aged asymptomatic female who now presents with no lymphadenopathy and a normal TSH level. Which of the following is the most appropriate initial step in management? A, CT scan of the neck. B, FNA. C, re-examine it. D, surgical excision. Or E, ultrasound of the thyroid. What would be the best answer here? Excellent. We have an asymptomatic thyroid nodule. Best answer is get an ultrasound first, see if there are any malignant features. The other thing that I want you to note is that if I had a low TSH level, not only would you get an ultrasound of the thyroid, but you will also get a radioactive iodine uptake scan. That is going to be indicated in a patient who is going to have low TSH level, because now you're thinking, hey, is the patient clinically or asymptomatically hyperthyroid? And I need to figure out what is the uptake going to be. Remember, if I see diffuse uptake in a RAIU scan, radioactive iodine uptake, you think of Graves. If I see a focal uptake, you think about toxic goiter. And finally, if I am going to be thinking of no uptake, I think about two things: thyroiditis, and I think about exogenous thyroid hormone, let's say for weight loss, etc. A newborn, well-appearing male who presents for routine evaluation and recently was born to an HIV-positive mother. In addition to administration of the Hep B, what would be indicated in the newborn? Lopinavir, ritonavir, and Bactrim, lopinavir, ritonavir only, penicillin, Bactrim only, or zidovudine. What would be the best answer? Absolutely. So the OB integration here is that you have a mom with HIV. Next best step in management, heart therapy for the mom. Especially if you initiate it in the second trimester, that heart therapy, you want to get the viral load down. That's super high yield. Remember that if the viral load is going to be low, you can then proceed with vaginal delivery. If the patient is uncontrolled, has a high viral load, is not going to be on heart therapy, then you may need to do C-section. But either way, for vertical transmission, prevention, and prophylaxis for the newborn, you want to give the newborn zidovudine for about 6 months or so. But, they'll be seen by their pediatrician and infectious disease at more frequent intervals. So best answer is going to be zidovudine. Oh, did I double click this slide on accident? There we go. Very nice. Which of the following is going to confirm the diagnosis? We have acute temperature instability and decreased activity in a premature neonate fed via orogastric tube who now presents with hypothermia, tachycardia, mild abdominal distension, blood-streaked stools, and leukocytosis. What would be the imaging finding that you would see on your most preferred imaging modality? How about that? Ha! What would be the imaging finding that you would see on the most likely diagnosis or imaging modality that you're going to utilize? Excellent. Pneumatosis intestinalis is the best answer. Remember that is going to be air within the bowel wall that you can see on X-ray, which is the correct answer here. Note that the premature baby who has feeding intolerance, you worry about necrotizing enterocolitis. Babies don't always mount a fever because of the immature immune response. And so, as a result, I apologize for the screen. And so, as a result, hypothermia or temperature instability is also going to be a bad sign. And these babies are going to get blood culture, antibiotics, urine culture, chest x-ray. They might even get a lumbar puncture. Blood-streaked stools telling you that it is a lower GI tract disease. This is not going to be volvulus or malrotation, which presents as bilious emesis, more upper GI tract. All right, we have about 8 more questions left. Are you all doing okay? We have over 100 people here. This is awesome. Thank you all so much for staying active and engaged. Big hugs to you. Let's keep going. This is an efficient use of our time. Thank you all for joining me this Sunday morning. It's my mom's birthday, so this is super fun. Doing a little review action before the festivities begin. All right, here we go. Acute seizure-like activity in a young woman with epilepsy who now presents with crying, falling, asymmetric kicking and thrashing, but there's no tongue biting. There's no urinary incontinence. There's no other abnormalities. So she has epilepsy and now these seizure-like movements. Could it be psychogenic? I think that's a very good differential consideration. But what would most likely confirm this patient's diagnosis? Interview, measure the serum antiepileptic concentration, serum CK, neuropsychological testing, or video EEG. What would be the best answer here? And so in this situation, the patient has epilepsy and now is coming in with epilepsy-like movement. Now, you may be thinking that this is going to be non-epileptiform in nature. However, could this be another semiology? And so Unfortunately, I would have to get her a quick CT scan, bam, admit her, and get a video EEG. If the video EEG captures one of these events and we notice that there are no abnormal spike waves, then yes, you can go down the route of management of the pseudo seizures, so to say. That's the old term. However, this is key. Epilepsy, new seizures, what do you do next? And you need to get maybe repeat imaging or definitely get an EEG. All right, here we go. Acute, sharp, unilateral chest pain in a young woman with recent upper respiratory tract infection who now presents with splinting over the unilateral thorax with deep breathing and negative cardiac exam and normal chest x-ray. Which of the following is the most appropriate next step in management? Is it A, a Zithro, B, CT angio, C, EKG, D, ibuprofen, E, prednisone, or F, get an echo? So we've already talked about a pleuritic chest pain after URI. So URI, we have pleuritic chest pain, but the patient is going to have it be positional, plus it is going to have a friction rub associated with it. That is going to be your pericarditis. Now at URI, and they were coughing a lot, etc., they're splinting, and they have pleuritic chest pain. It could be positional, but primarily, remember, on palpation, it is going to be very tender. That is going to be very characteristic of costochondritis. Now, for both, you're going to employ NSAID therapy, and that's key. Now, splinting means that they're trying to take a deep breath, but they're not getting the most effective deep breaths. And so this comes up in your surgery shelf. When you have a patient with uncontrolled pain, they'll take a deep breath, and they can run the risk of atelectasis and subsequent pneumonia. So that's why, as an intensivist, I make sure the child has good pain control, not too much for respiratory depression, but also not too little. So they have splinting, and thus they could have poor alveolar recruitment, i.e. they could develop atelectasis. Another very important vignette is a patient who coughs because of the recent URI, and now they suddenly have crepitus in the supraclavicular region. What do you think is the best answer here? I coughed because of my upper respiratory tract infection, and now I have subcutaneous crepitus. What do you think is the best answer here? And this would be potentially a spontaneous pneumothorax or a slight little pneumomediastinum. And this is all just due to the fact that there was a high violent force that may have popped open some small alveolar blebs. And so next best step in management for this would be, hey, we need to get a chest x-ray. That's high yield. So cough, crepitus, a little bit of spontaneous pneumomediastinum type of jazz. Vomit. And then you see crepitus. Boerhaave syndrome, Boerhaave. Vomit, crepitus. Your Mallory-Weiss turned into esophageal microperforations. Next best step in management, get a water-soluble esophagography. Very high yield. Yep, beautiful. Almost done, guys. Let's hang in there. Chronic secondary amenorrhea in a young sexually active female combat veteran with history of prior normal periods who now presents with normal TSH, a low normal FSH-LH, normal prolactin, and a negative beta-HCG. Which of the following is the most likely cause of the patient's amenorrhea? A, Turner's, B, hypothalamic hypogonadism, C, polycystic ovarian syndrome, D, premature ovarian failure, or E, a prolactinoma. Best answer here? Excellent. So she recently had normal periods, and maybe this combat veteran had traumatic brain injury, and that traumatic brain injury may have caused her to have some hypothalamic and pituitary dysfunction. What you notice here is that this patient has hypothalamic hypogonadism, whereas what you want to note for Turner's premature ovarian syndrome, premature ovarian failure, what you want to note in those pathologies is this would be hypergonadotropic hypogonadism. So in these situations, Turner's and premature ovarian failure, LH and FSH are high, and the gonads are not working, i.e., you have signs of estrogen dysfunction. Another high yield thing for us to know is that PCOS has an LH to FSH ratio that is going to be elevated. However, you want to note that the patient on physical exam also may have abnormal periods and signs of hirsutism, because the elevated LH hits the theca interna cell and can give you some hair in the male distribution, so to say. All right, very good. Chronic secondary amenorrhea. I'll pause here real quick. What's the most common cause of chronic secondary amenorrhea in the world? Most common cause of chronic secondary amenorrhea. Oh, hello, everyone. Yes, very good. Pregnancy, beta-HCG. Yeah, wonderful. Chronic secondary amenorrhea in a middle-aged sexually active female smoker with previous normal cycles who now presents with a normal physical exam. Measurement of which of the following serum concentrations is most likely to confirm the diagnosis? Estradiol, FSH, beta-HCG, luteinizing hormone, or progesterone? What do you think is the best answer here? All right. Best answer here is going to be FSH, because the diagnosis is most likely going to be in this situation, and maybe I may have also left out some information, but a couple of things here. I can understand beta-HCG, secondary amenorrhea. If she was pregnant, then yes, that's why she had it. I think I left out a few details, so I apologize on that. But remember, FSH confirms premature ovarian failure, and it also confirms menopause. So I think the free 120 says B, FSH is the right answer. They may have mentioned that the fact that the patient is non-childbearing age, etc., and they are going for the fact that she may have ovarian failure in the sense that the follicle in the ovary is not maturing as well. But you're absolutely correct. If you're thinking about, and read the whole question in the PDF, if you're thinking about, if I have secondary amenorrhea, I need to get a beta-HCG. That's very high yield. Okay. All right. Sorry about that. 6 more questions. Here we go. Evaluation of hemoglobin FS in an asymptomatic, developmentally normal infant who has been gaining weight appropriately. In addition to routine anticipatory guidance about feeding and development, the mother is instructed to observe the patient for pallor and fever. Also, is instructed to palpate the spleen. Which of the following is most appropriate to prevent complications in this patient? So, amoxicillin as needed, instructions to palpate the long bones routinely, instructions to check the baby's pulse, low dose aspirin, or oral prophylactic penicillin therapy. What do you think is the best answer here? Excellent. So this baby is potentially going to have sickle cell disease. And remember, as you are going to go across from 6 months, you go from the fetal hemoglobin to your more adult hemoglobin, which is alpha 2, beta 2. However, you can accumulate, if you have sickle cell disease, a lot of hemoglobin S, and you can, after 6 months, present in bone crises. You can have chronic hemolysis and thus splenomegaly. And so to prophylact against encapsulated organisms, you want to employ penicillin therapy. All right, here we go. Subacute jaundice and acolic stools in a neonate who now presents with tachycardia, hepatomegaly, splenomegaly, with labs notable for hyperdirect bilirubinemia. It's a direct hyperbilirubinemia. What is the next step? So we have acolic stools and signs that the gallbladder is obstructed. Go ahead and type into the chat box what would be the likely diagnosis you would be thinking of in this situation. And if you're saying biliary atresia, you are absolutely correct. Remember, the acolic stools is because the bile is unable to get to the duodenum. So if the bile is unable to get to the sea of the duodenum, you don't have the stercobilin that makes the stool brown. And thus you can get clay-colored or acolic stools. These patients are going to have now bile that can be toxic to the hepatocyte, and thus they can have a transaminitis. And again, it's post-conjugation. So that's why there is a direct hyperbilirubinemia. Best answer is ultrasound of the abdomen. And these patients get a procedure known as a Kasai procedure. Go ahead and just Google image Kasai procedure, and you'll see how they hook up the jejunum directly to the liver to drain out some of that bile. All right. Subacute non-productive cough in a middle-aged female who recently was diagnosed with hypertension, started on lisinopril, who now presents with improvement in blood pressure and clear lung auscultation. So she was started on a ACE inhibitor and now has a cough. What would you do as your next best step in management? PFT, CT scan, give some prednisone, discontinue the lisinopril, use of a cough suppressant, or no change. And so if the answer is D, you're absolutely correct. You can switch to a sartan. Remember, sartan is going to be a angiotensin II receptor blocker. And so this ACE inhibitor induced cough is going to be due to increased amounts of bradykinin. And that increased amounts of bradykinin is going to be integrated into a pathology. Whereas if you have C1 esterase inhibitor deficiency, which is essentially going to be hereditary angioedema, ACE inhibitors are contraindicated because you are not going to have effective pathways to metabolize your bradykinin. And as a result, ACE inhibitors contraindicated because too much bradykinin can cause you to have lip swelling, tongue swelling, and airway compromise. Which of the following is the most likely adverse effect of an IV opioid in this patient? We have acute pain in a young, healthy female currently in labor who is now noted to have cervical dilation, effacement, and regular contractions. She's going to have a baby. She is requesting opioid therapy. Which of the following is the most likely adverse event of an IV opioid in this patient? Go ahead and type into the chat. Excellent. If you're saying neonatal respiratory depression, you're absolutely correct. Please note that the contrast would be, let's say that I put a acute pain in a chronic opioid user If I change that the mom maybe had poor prenatal care, was a chronic opioid user, then the baby can have neonatal abstinence syndrome. And neonatal abstinence syndrome is going to present as a jittery baby with a high-pitched cry. Now, a jittery baby with a high-pitched cry, one of the illness script modifiers here is they'll say that the baby is sneezing. And so in this situation, you would go down the protocol of neonatal abstinence syndrome, which is giving them some opioid back and then slowly weaning that over time. But they are going through acute withdrawal because of the mom's chronic opioid dependence. So there's another variation of the vignette. Okay. All right. I think we are at our last 3 questions. Is everybody ready to get this series of questions done? I hope you all have learned a lot so far. Thank you guys so much for sticking with me with these integrations. Sometimes it's a roller coaster, but this is just my mind stream of consciousness going. I do prepare some things ahead of time just to fit in there, but sometimes I'm just talking about the things that I see very high yield as I go through UWorld and NBMEs, etc. So thank you all. Chronic behavioral abnormalities in a school-age child who has an inability to sit still, is learning at a slower pace, snores at night, and wets the bed several nights a week. On physical exam, she has enlarged tonsils. What is the next step in management? Go ahead and type into the chat what would be the next best step in management in this patient. Now, right away, you may say, oh my gosh, inability to sit still, that activates the illness script of ADHD, and that's fine. I get it. However, the best answer encompasses the most data points. Remember that the snoring and the tonsil enlargement brings up OSA as a consideration. And remember, you get bad deep sleep regulation, etc. So secondary enuresis, where the baby is dry before and now starts peeing the bed, secondary enuresis, you worry about 3 things: OSA, you also worry about diabetes because of the high glucose osmotic load, and you worry, unfortunately, about sexual abuse as well. So what is high yield for us to note is that in this patient, you want to note that they could have a OSA or polysomnography and then a subsequent TNA, which is a tonsillectomy and an adenoidectomy. And then remember that if the patient has long-standing OSA, they can present with pulmonary hypertension. And pulmonary hypertension presents with fatigue, shortness of breath, JVD, and hepatomegaly, signs of right-sided heart failure, because the pulmonary vasculature is going to be chronically vasoconstricted due to the OSA. That's why we treat it. All right. Acute, increasingly severe unilateral foot pain in an obese, middle-aged male with type 2 diabetes and recent low-impact trip or fall, they fell, who now presents with reassuring vitals, decreased pulses in the pedal region. Do you see how that is integrated with this right here? Unilateral foot warmth and midfoot tenderness. Which of the following is the next best step? A, get uric acid. B, venous duplex ultrasound. IV vanc. Immobilization of the right foot in a posterior splint. Or E, surgical reconstruction. What do you think is the best answer here? Okay, this is great. I love it. I love it. I love it. I love it. Now, this question is going to be a foot pain after trauma, after a fall. Now, in this situation, what you want to do is you want to immobilize the foot, because focal tenderness in that midfoot region is pointing to a fracture. Reassuring vital signs. Remember, reassuring vital signs are going to tell us, hey, no fever, And so this is not going to be cellulitis or a septic joint. And then remember that this is going to be of the foot. There's mid-foot tenderness. There's foot warmth. Typically, you would be thinking of calf tenderness, edema, and plus or minus warmth if there was thrombophlebitis. And that would activate your illness script that we are talking about, a DVT. So best answer here is going to be for a fracture, immobilize the foot. Acute motor vehicle collision and hemorrhagic shock in a young boy who now presents with splenic injury, severe anemia, and we're giving them rapid infusion of saline. The patients say, hey, my kid is in hemorrhagic shock, but religiously, I do not accept blood products. Would you give this child blood, yes or no? Go ahead and type it into the chat. Excellent. These are very challenging ethical scenarios, but we have a duty to respect a minor's autonomy, non-maleficence, do no harm, and beneficence, do for the greater good. And so in this situation, you will proceed with the blood transfusion, stabilize the patient. In emergent situations, you have to stabilize the patient, and then you can have this long, drawn-out discussion, but they're not going to test you on that because it's so individualistic. But you want to make sure that if this is a reversible, life-threatening cause, you have to resuscitate the patient. Acute tachypnea in a newborn female born to a mother with limited prenatal care who now presents with tachypnea, hypotension, single loud S2, prolonged capillary refill, hepatomegaly, and metabolic acidosis with a chest x-ray significant for very increased pulmonary haziness and vascular markings. The most appropriate next step in management for this neonate who presents in signs of cardiogenic shock, as you can see, tachypnea, hypotension, a loud S2 makes you think about many sort of diseases, particularly even truncus arteriosus is a good one. But again, the patient has signs of distal perfusion that is going to be compromised. So yes, would you be worried about sepsis? The answer is absolutely. But then if you notice that the patient has pulmonary haziness, you're noticing that the patient's myocardial function is not good and everything's backing up. Could this be total anomalous pulmonary venous return? Could this be truncus arteriosus with poor function? Could this be something like hypoplastic left heart syndrome where you can't get good drainage into the LV? So PGE2 keeps the ductus arteriosus open, and that is why that is the best answer. I think there are two more, and then we are going to be done. This is the first one, and then we have one more. All right, here we go. Subacute follow-up for chest pain in a middle-aged woman who was recently hospitalized for episodic chest pain with diffuse ST segment depressions, who now presents with cardiac cath, showing no substantial narrowing of the coronaries, as well as recurrent crushing, aching chest pain and normal troponins. She continues to have these recurrent episodes. What is going to be the likely diagnosis first? What is the likely diagnosis? Episodic chest pain, diffuse ST depression, and this patient has normal coronaries. And if you're saying that this is a vasospastic or Prince-Meadows angina, you're absolutely correct. And so if we have vasospasms, we usually do diltiazem. Remember, vasospasms of the fingers, rheumatology integration, Raynaud's phenomena. So if this patient had atherosclerotic risk factors, yes, propranolol would be the best answer. But we notice that this is a vasospastic episodic angina. So watch this. Diffuse ST segment elevation, pericarditis. Diffuse ST segment depression. You think about vasospastic angina, undulating QRS complexes. You can think about electrical alternans, but even undulating wide QRS complexes, you worry about torsades as well. This is our last question. You guys ready to rep it out? Had a little bit of a fall off of people. That's okay, though. I appreciate you for rocking it with me today. It's been a long session. We are still here. I love it. Thank you so much. I promise this is the last question for today. Here we go. Acute exertional syncope without loss of bowel and bladder that rules out a seizure in an elderly male with hypertension who presents with bradycardia, low normal blood pressure, and this EKG. Now, this EKG, when I see this, I just say, wait a second, these are grouped beatings. Here's QRS complexes, here are QRS complexes. And whenever I see group beatings, I worry about AV block. Now, in this situation, if I see that the PR intervals are going to be relatively fixed, and then there's a drop, they're not lengthening, I know that this is definitely not Mobitz type 1, but this is going to be Mobitz type 2. And remember, first degree AV block is not symptomatic. This patient had syncope and has a heart block. Other things you consider, EEG, but there were pertinent negatives here. And then you also consider valvular heart disease. Aortic stenosis presents with syncope, angina, and dyspnea. We are done. Thank you so much for joining. I would love, before you leave, if you can just stick around for just a couple announcements. If you have not yet seen this kick-ass website, ChatGPT, USMLE.com, I teamed up with Jake Portnoff from Med School Bro. He has awesome, awesome content. We teamed up and we created a series of prompts that you can use, very innovative, for ChatGPT. If you are interested in any of my courses, go to my website, HyGuru.com. And for you all today, I would highly encourage, if you like the way that I was teaching, I would encourage you to go through my clerkship-based Step 2 CK Rapid Review, mapped questions at the end of every video. It is integrative, it is high yield, and many students have found this very, very effective, especially when they're on their clerkships right before their exam or if they're in dedicated study. This is an integrated course. You get a UWorld Notes template guide as well. And before you leave, I would encourage you to kindly share what you loved about HyGuru. Feel free to put your review of this session and my resources right here into my review platform. I would love to highlight bright students like you. One student at a time is my mission, and I hope you join me in serving that mission, because we are not just here to kick ass on an exam. We're here to make sure that you can really effectively excel as a resident and beyond. So I appreciate you all spreading the word, and I am done for today. So please type in one thing that you learned, and I will see you all in block 3. Coming up, coming at you, block 3. All right. Very good. Thank you all.